So we'll continue the topic of vertigo. So we were discussing about the vestibulo-ocular reflex. This reflex is for gaze stabilization during the head movements. So whenever our head is moving or we are walking or driving or on any movement, so we need to focus on one object, and that is what is done by vestibulo-ocular reflex. So it integrates the signals from the visual as well as the proprioceptions also, like during walking and riding or any movement of the head. If viewer is not there, our visual acuity will decline during the movements. Like we are like sitting straight and we are watching one static object, and if we are moving, we are seeing the same object with the same clarity. So that is what the viewer is required. It is the gaze stabilization on one particular object during the movement. So if we are moving, our eyes should focus on the same object again. So now we come to the central vestibular connections of the otolith organs. As we have discussed, similarly, utricle and the anterior superior part of the sacule, some part of the sacule. Mainly utricle and some part of the sacule is supplied by the superior vestibular nerve, and a major part of the sacule is supplied by the inferior vestibular nerve. This is the first order neuron here, which reaches the medial and lateral vestibular nuclei. Here it synapses, and from here the second order neuron continues to the anterior horn cells of the cervical spinal cord. And we call it as a medial vestibulo-spinal tract from the vestibule up to the cervical cord. So it is the vestibulo-spinal tract. So from the medial vestibular nucleus to the anterior horn cell, this is the medial vestibulo-spinal tract. From the lateral vestibular nucleus to the entire, most of the spinal cord, it is the lateral vestibulo-spinal tract. Okay, they take the signals from the anti-gravity muscles of the neck, thorax, and the lower limb. Okay, so basically, if we are standing, so the anti-gravity muscles of the lower limb, back, and the cervical muscles, they are always on work, and they give signals by which our brain assesses or the our position or the posture in the space, or the orientation of the posture in the space. Some of the fibers from this vestibular nucleus, they goes rostrally to the extraocular muscles also. And these fibers are responsible for the some rotational or the vertical ocular adjustment. And here, these fibers are responsible for the rotational or the torsional nystagmus. Okay, there is a component of the torsion in the nystagmus sometimes when it is a vestibular in nature. So these fibers from the spinal cord or the anti-gravity muscles, they are responsible for this torsional component. So here we can assess utricle and sacule, which are the otolith organs. They are in direct connection with the spinal cord. Okay. The central vestibular system continues, and it is a major important part in the cerebellum. Cerebellum, it gets innervation from the direct from the eighth nerve and indirect vestibular inputs also. The cerebellum is uh, it's responsible for the inhibitory influence uh, of the Purkinje fibers, and that causes the fine tuning of the ocular and postural motor activity. So whenever there is a vestibular input, vestibular signals are there, there will be some ocular movements, there will be some motor activity of the lower limbs or back or the neck, but these all cerebellum works for the fine tuning of these motor responses. Okay, so cerebellum is a check post. So it gives an inhibitory influence. It should not overshoot that function. If I'm trying, if I'm like my head is tilting toward one side, and my body is, the brain has sent signal to correct the posture. It should not overshoot. I should not fall on the other side. Okay, so this cerebellum keeps a check over this thing. So it is the fine tuning of the response motor activity, and this fine tuning from the cerebellum that regulates the vestibulo-ocular reflex and vestibulo-spinal reflex. Okay. Now we come to the cortex. There are some areas in the brain like vestibular nucleus and thalamus, superior sylvian gyrus, inferior intraparietal sulcus. They ultimately send signals to the mesencephalon and the cerebral cortex. This all we call this all fibers as the ascending vestibulocortical pathway. Okay, this is the ascending from vestibule up to the cortex, vestibulocortical pathway, and what it does, it integrates the visual, vestibular, and proprioceptive signals. They integrate finally to produce the conscious awareness of the body, and it is the orientation. We as a our brain knows where exactly our body is uh, maintaining the posture. So it is the orientation of your posture, three-dimensional orientation, and that is done by this vestibulocortical pathway. So So initially we started from the vestibular system and vestibular central connections. Now we come to the visual system, the second sensory inputs. We sense the surrounding through the eyes also, that for the picture which is presented to our retina or the fovea. So there are multiple systems for the visual inputs. One is saccadic, some is pursue movements, and optokinetic movements, and some more. So we'll start with the saccadic eye movement. So what are saccades? So initially we discussed that whenever our head is moving, our eyes try to focus on the one uh, target or one already target where already the eyes are focused. We try to focus on the same object. But what happens if our field of vision is changing while moving? If I am seeing one object at the same time while moving, if I try to focus on the other object, so that jerky movement is second. While moving, the target is changing. Okay, so the second is in saccadic movement. What happened in VR? What was happening? The head was moving, but the target was same, and then it was static. But in saccadic movements, the head is moving at the same time, your target is also moving. Okay, target is we are trying to focus on the new target. It is the saccadic eye movements are used to change the gaze to a new target appearing in your visual field. Whereas viewer stabilizes gaze during the head movements on a stable target. That is what the difference you should know. Now there are again two types of saccades. It is voluntary and involuntary. So voluntary change in the gaze requires ipsilateral and a contralateral conjugate eye movements. So if I'm seeing this object, if I want to focus on the other object, there will be conjugate eye movements of the conjugate eye movements. Ipsilateral movement of the eye is regulated by the frontal eye fields of the brain, where the contralateral eye movements are managed by the oculomotor nucleus. Okay, now we'll come to the involuntary saccades. So, suppose we are watching or we are seeing one object and our head moves suddenly. So, whenever our head is moving, there will be a vestibular stimulation. And because of the vestibular stimulation, there will be a reflex eye movement, which is known as the involuntary saccade. And that involuntary saccade tries to return the eye to the neutral position. If I am watching one object, if I suddenly give a jerk over the head, and my eye will try to focus on the same object. It is not focusing on the other object. If I'm voluntarily trying to move on the other object, it will be voluntary saccade. If I am not trying this thing, it will be our eyes will again focus on the neutral object. The first one. This will be an involuntary saccade. Saccades have got four characteristic features. One is the accuracy, and then a high, it is of high velocity, short latency, and a conjugate deviation. So accuracy, it means there should not be an overshoots or undershoots. It is controlled by the cerebellum and the fastigial nuclei of the brain, where the high velocity, short latency, and a conjugate deviation, simultaneous deviation of the right and left eyes. It is managed or controlled by the brain stem or the frontal eye. Okay. So we'll continue with we finish with the saccadic movements, saccades, and what are the smooth pursue eye movements? What we have discussed till now is head movement and the target was static. But what if while moving, if we want to follow a moving object? So this is called a smooth conjugate eye movement. So this movement is for tracking small, slowly moving objects in our visual field. So here, even there's a movement of our head also, as well as the movement of there is a moving object. So we want to see clearly and within good visual acuity to the moving object. So the smooth pursue movement helps in that. So it is in the form of this flowchart, slowly moving object in the visual field. It comes, there is a moving object in the visual field. Then it will give a signal to the retina. These retinal signals will reach visual cortex. Visual cortex, from visual cortex, the accessory optic tract and superior colliculus. It will reach the vestibular nuclei here. And here there will be a comparison of this eye movements with the head movements. And ultimately there it will reach into the oculomotor nuclei. Here it generates optimal eye movements for tracking the moving object. So in smooth pursue movement, we are while moving, we are observing or watching the moving object. In saccades, we were watching the static object. That is the basic difference. So smooth pursuit movements, they decline with the age. As our age progresses, our movement is re- reduces its sharpness. It's with a reduced visual acuity, target speed, and if you have taken some medicines, sedation medicines, inattention, and this all will reduce the acuity while uh, observing the a moving object, as well as some lesions of the cerebellum, because as we have already seen in the last slide, this all central connections are involved in this thing. So cerebellar lesion, cortex lesions, or brainstem lesion will reduce the smooth pursuit eye movements. So whenever there is if we do a video nystagmography and then there is some problem with the smooth pursuit movements, we can assume that there will be some central pathology for this. So now we come to the optokinetic movement. It is same as the smooth pursuit movements, just that it this optokinetic movement senses this moving object with the peripheral visual field, whereas in smooth pursuit movement, the tracking of the slowly moving object it was with the foveal. Okay, otherwise, the both are same, and if one is affected, the other is going to be affected. Okay. So key points to be remembered here: vestibular reflex to keep the static target focused on the fovea with minimum. What is VR? It is to keep the static target focused on the fovea with minimum with a maximum acuity during head movement. Saccadic and pursuit or the optokinetic movements, they are used when the object is changing or moving. Vestibular reflex needs to be suppressed while tracking a moving object, because pursuit movement, they are following a moving object. But viewer, if the viewer is very strong, it will reduce the perceived movement. But if we want to follow a moving object, we need to suppress the viewer. So both work in opposite direction. Vestibular, vestibulocerebellum, or the flocculus, paraflocculus, and nodulus, these three parts, the lesion of this part, they decrease the fixation suppression, they impaired pursuit movements, impaired optokinetic movements, and poor gaze stabilization. So basically, whenever there is a lesion in the cerebellum or the vestibular cerebellum system, there will be loss of all these eye movements, and that we can check or with the video nystagmography. So with this, we can uh, locate the site of the lesion. Asymmetric firing from the vestibule gives sense of motion and a jerk nystagmus toward the higher firing vestibule. The purpose of this reflex is stabilization of the gaze with head movements. Here in this picture, we can see that if this is the labyrinth and our head moves in this direction, there will be uh, increased firing rate of the right side, decreased firing rate of the opposite side. So this arrow, this dark arrow shows the increased firing rate, and this small arrow shows the decreased firing rate of this side. So whenever our head moves like this, our eyes try to go towards the opposite side, left side. And there will be a corrective eye movement towards again the same side. The slow component towards the left side and the fast component towards the same side. Similarly, same situation happens in here when the head is not moving, but one uh, labyrinth has got damaged. One labyrinth has got damaged. What happens? This the brain will the signal from this damaged labyrinth will be zero, and this normal firing rate of the normal side, it will be considered as an increase in the firing rate, because here we compare on the right and left. So here that increase on this side, it was because of the movement, but here there is no movement, but there is a difference in the right and left signals. So again, our brain senses that our head is moving towards the right side and the eyes will go towards the left side, and the corrective movement again will be towards the right side. So here, if the one labyrinth is damaged completely and there will be no signals, so actually the right one becomes the uh, increased firing, or maybe the irritable labyrinth, and there will be nystagmus on the normal side. So without head movement, if the labyrinth is damaged, there will be a nystagmus towards the normal side. And suppose if it is an irritative labyrinth, there will be increased firing rate. The nystagmus will change its direction. So vestibular inputs. What if uh, basically our brain like, judges the uh, signals from both the labyrinth? What if signal from both the vestibular sides they are lost, just like an autotoxicity or trauma or autoimmune disease? Both the vestibular inputs are lost. Then there can be a very mild asymmetry of the vestibular signals that will lead to very minimal vertigo and nystagmus. There will not be any vertigo or the nystagmus if both the labyrinths are not working, or might be mild asymmetry will give you mild symptoms. But the main symptom will be the patient will not be able to focus uh, uh, on any specific object while head moving. So there will be jiggling or the bobbing of the visual field or visual word with the head movement. Whenever he will be moving, the picture will be moving on the retina. So due to the loss of the stabilization of vestibulo-ocular reflex and repeated slippage of the image, there will be repeated slippage of the image from the retina during the attempted fixation with head movements. So with the head movements, our VOR will try to fixate the image, but it will not be able to fix it. And there will be repeated slippage of the image. So it is called as an oscillopsia. It is moving like in right or left in either direction. So it is oscillopsia is in cases of when both the sides of the vestibular function is lost. Now we come to the somatosensory part, the third sense organ, which is from the pressure and the joint proprioception. It is for maintenance of the static balance. The inputs from the pressure receptors of the foot and stretch receptors of the cervical, thoracic, and lumbar muscles. They give inputs. It is afferent uh, spinal reflex arch, and they ultimately through the vestibule and through the central nervous system, they ultimately go to the again for the extraocular muscles and the uh, uh, muscles of the lower limb and back and shoulders to maintain the balance. And if this system is deranged, just like in cases of the peripheral neuropathy, in cases of uncontrolled diabetes, the peripheral neuropathy, the patient is not able to sense the posture in the joints and the sole or something. The patient will lose the stability. Like if we are walking in a dark situation, or maybe in an unstable ground, or maybe we are standing on a soft ground, like we are standing on a foam. This will remove this sense organ and will totally depend on the visual and vestibular system. And that too, if you are standing on a soft foam or a irregular surface, along with eyes closed, we will be totally dependent on the vestibular system. So with these three, we need to check one by one, and then how to examine a patient who presents with a symptom of vertigo. Uh, we need to check all the three systems: vestibular, visual, as well as proprioception. And one by one, we remove, we do this stepping step Attenberger test. We remove the visual field, and after that, we check for the labyrinthine system, vestibular system. So we all the three sense organs we need to check to locate the site of the lesion. Thank you.